perspective, although it's difficult by Zoom, I'm more than happy to keep this as an open discussion as much as possible. So if there's something you don't quite get or understand, or you disagree or do something differently at your institution, there'll be time at the end, but also interrupt as we go along. Just maybe identify yourself and what institution you're working in, and we'll move forward. So I think we'll jump right into it here. Abby sent out some objectives. This is the bridge to decision patient population for end-stage heart failure that we're talking about, acute heart failure. And we'll review some of the background around bridge to decision therapy, patient selection and timing of referral, absolutely critical. These are probably the two most important factors to consider if you want to build and maintain a successful program. We'll talk a lot about device options. Not all of them are utilized here in Edmonton. I will focus on the ones that we used here and the experience of our team here, but I'll also spend some time on other options as well. And I'm sure there's expertise in the group that could expand on details with some of the devices that we're not really using a lot in Edmonton. To give you a little bit of background for those of you who do not know, we have a transplant and a VAD program, a bridge program, and a durable LVAD program. And we're doing, the numbers are variable per year, but it's probably in the range of 30 heart transplants, in the range of 20 to 30 durable VADs, and similar number, maybe a little bit more of bridge to decision VADs, and a similar number of ECMO patients. That does not include VV ECMO patients, and obviously the numbers vary from year to year. We'll talk a little bit about current evidence and expected outcomes. You'll quickly learn that there's not a lot of evidence and not a lot of great information on outcomes. So that's definitely an area that we're going to need to, we'll look forward to some progress in the coming decades to guide us in terms of patient selection and matching devices to patients. And then a theme throughout the talk will be the importance of a multidisciplinary team. Absolutely critical. These are complex patients that require complex decisions. So everyone's seen this this diagram or outline of the INTERMACS profiles. Essentially what we're talking about here is the INTERMACS I patient, the quote unquote crash and burn cardiogenic shock patient. We will slide a little bit into the INTERMACS II group in this discussion, because there are perhaps very specific circumstances where we might consider a bridge device in an INTERMACS II patient. I would say it's somewhat rare, and the vast majority of patients will be in that INTERMACS I group. I like to start these talks with a case presentation, something to hang our hats on and think about as we move through the discussion and maybe bring it back to the patient. I chose this patient because he's a recent patient, a currently hospitalized patient that we're currently looking after, and he illustrates a lot of the points that we're going to be talking about as we move through bridge to decision therapy and treatment. So Mr. S, he's 22. He's a large young man, I would say 110 kilos. I think he's about 6'4", 188 centimeters. And he is referred with an idiopathic cardiomyopathy. He basically presented to the referring hospital with fatigue and really quickly advancing shortness of breath. He was probably class 3 when he presented to the emergency department. Some initial investigations there and clinical signs of heart failure resulted in an admission. And he went on quite quickly to heart failure cardiology admission. He was quite stable. He had a transthoracic echo showing severe biventricular dysfunction, left greater than right. His EF was in the 10% range. That's probably generous. And he had an MRI cardiac. Again, confirmed LVEF 10%, RVEF about the same. And you can see his end diastolic volume here on the MRI, 640 mLs, and that is in the gigantic range, probably 3 times the normal LV size, considering his overall BSA. I couldn't get this video to work, but I think this demonstrates nicely here the size of the left ventricle and the thinning of the wall. So when looking at this, and it's a constant judgment of, okay, is this a recovery situation or not? When you see a ventricle this size, well over 8 centimeters, I would say many of these ventricles don't recover. It's not that we eliminate that possibility completely, but at a certain size, they just don't seem to recover. Whereas if he shows up with an EF of 10 to 15% and the LV size is relatively preserved, it suggests a less chronic situation and maybe a higher likelihood of recovery. So he was stable until he wasn't. And this is quite a typical scenario for these patients. He went into refractory VT one evening on the ward and quickly deteriorated to a CCU, CICU admission and cardiogenic shock. He was hypotensive, lactates already creeping up, and SVO2s in the 30s, and creatinine and LFTs already going up. So this is a situation where you get the sense that there are severe time restraints. He's okay, but he's what I would refer to as a pre-CPR patient that, you know, you're really feeling pressed to make decisions in the next 30 to 60 minutes in regards to this patient's care, for fear that you might be doing CPR and in a much worse situation. His lactate levels, creatinine and LFTs are probably not going to rise that quickly unless he arrests, and that's the biggest risk, and really pushing us to make a decision in the bridge to decision mode, if you will. And I mention that timing because that timing will have a significant impact on the decision. Relax a little bit, take a little bit of time. There's no arrhythmia, he settles down. Then other options are on the table. When you're in within severe time restraints, and the options become much more limited. So next steps on this patient, I'll answer the question. The decision of the team, I think there still are a couple of options here, but they made a good decision to put this patient on ECMO. And then again, with ECMO, there are many decisions that can be made. Can we get this patient to the operating room or the cath lab, or do we need to do this in the CCU? And then if we can get to the operating room, it opens up potential different cannulation strategies that might not be available, or definitely are not available in the CICU. So if he were to arrest, for example, this would be a fem-fem cannulation by Seldinger technique in most institutions. They felt, although he was in VT, he did have a pressure in the low 90s, and he was neurologically responsive and intact. They did feel that they had an hour to get the team in and get him to the operating room. And they ultimately decided on a right axillary arterial cannulation with a graft and a femoral venous cannulation, which I think is a good option in this patient. It's an option that we occasionally use in Edmonton. I wouldn't say we use it a lot. There are considerations around this access. It's not a CPR access, if you will. Getting a graft on that subclavian artery is difficult under CPR, so that would be more of a fem-fem Seldinger approach. But in a relatively stable patient where you feel you can provide them an anesthetic safely or reasonably safely, this is a good option. So he was on this this approach for ECMO for 14 days, which is incredible, really. We would consider that in Edmonton a very long time. There were different reasons why he was on that time. He had numerous complications, including pneumonia. There was an element of empyema. He had pancreatitis and the early development of a pancreatic pseudocyst, renal failure, dialysis, and it did take some time to determine whether or not, in fact, he could recover to the point where he would be a reasonable candidate for the next step. So ECMO here is essentially serving as a bridge to bridge, which is another concept that we'll talk about during this discussion. So after 14 days, again, an incredibly long time, but he is young. He's 22 to be on ECMO, and we'll talk about timing and transition steps and bridge to bridge a little bit later on in the talk. The decision was he was too sick for a durable LVAD at this stage. There was the biventricular right-sided component as well, and the decision was made to transition this patient to a CentraMag centrifugal LVAD. They had their right axillary access, which it made sense to use, I believe, at this time, and then they elected for an approach that we haven't used or don't use in Edmonton for left-sided heart drainage and return to that pump and and that's the right superior pulmonary vein through a mini thoracotomy. And it worked incredibly well, actually, from a flow perspective. And then he starts his journey at that point of recovery of all of his end organs, because this is a young man that's still in renal failure, on dialysis. Chest x-ray looks not great. And then he's got these other pancreas issues, sepsis issues, pneumonia issues. So there is a sense that this is going to take some time. And over a 14-week period, he recovered essentially all of his end organ issues. And then we need to decide on the next step for him. And this is his chest x-ray here. So you can see this cannula coming in through the right chest into the left side of the heart. It wasn't a long cannula, so it did not pass across the mitral valve, and we'll talk about that. And then you can see some clips and things here up in the right axillary area. I will say that he did require several trips to the operating room for bleeding through that right axillary cannula. And it was actually bleeding through the graft material itself. And if you're going to use that strategy, it can be helpful, just a little bit of a clinical pearl to wrap at the time of surgery, wrap a second graft around your 8 or 10 millimeter graft going on to the axillary artery. That can help with bleeding through the graft material when this graft is really exposed somewhat to the outside world for a prolonged period of time.
Dr. MacArthur, can I ask a quick question?
Yes, of course.
Yeah, so I just want so the original for cannulation strategy, I was just curious, so do they do the percutaneous femoral vein?
Yes.
And is that, so did they, because of his size, did they want to avoid opening his groin, and that's why they went axillary? I guess because traditionally, well, what I've seen, they usually just do fem, but it was because they were trying to avoid an incision in the groin. That's why they did the axillary.
I don't know about that, Abby. His groins are just fine. I mean, he's a large man, but he's only mild to moderately obese.
Okay.
I think they were already thinking towards the next step,
okay,
which is their CentraMag, where they wanted to use that right axillary artery.
Gotcha.
And I think it is a good strategy for CentraMag, as long as you don't have, we do most of ours, as you know, centrally. But as long as you don't have bleeding through the graft, and that was the major issue for him. He required 5 re-explorations of the shoulder, lots of foreign material in there. The shoulder was essentially open for about 3 or 4 months. So there was a lot of difficulty there. The advantage to it is you get that antegrade flow through the arch, which is potentially less damaging or risky to the brain from an embolic perspective. And he did have many emboli, but none to the brain. They all went to the spleen and the liver, and he was just fine with that. So there may be some advantage versus the ascending aorta, where everything's kind of turbulence-wise sent upstream into the innominate and the carotid vessels. Did that answer your question?
Yes, thank you.
Yeah. Okay. So he is on for 14 weeks, recovered all of his end organs, and then we come to the next decision. And there's a lot of discussion between them. He's still at the referral hospital. Do we go durable VAD in this patient, or do we list him for transplant? And ultimately, he was listed for transplant. And what probably tipped the balance was the very real concern that his RV may be an option, may be an issue for him with durable LVAD. In any event, he was listed. There were concerns around his size, but very fortunate, in a relatively short period of time, we got a 130 kilo local donor and transplanted him. So there's his chest x-ray now, a month post-transplant. This is actually a normal chest x-ray, still looks like a big heart. I can tell you the donor heart was gigantic, but it was still only about a third of the size of the patient's heart. So really, really good heart. He's about to go back to home hospital, and really he did require a plastics operation in his right shoulder to debride some muscle necrosis issues and things in that right shoulder, but that seems to be all healing up reasonably well. He's got some numbness in his right fingers, as you can imagine, and he's just starting to walk, which is incredible considering he was bedbound essentially for 4 months. So he's walking with a walker, and at 22, he'll recover all of these issues. I like this slide, Edmonton River Valley, just nicely illustrates that these bridge devices are temporary devices, and they're bridged to recovery of the organ or long-term therapy, of course, which could be transplant or durable VAD, or bridge to outcome, which could be death of the patient. And we do need to realize that this is a very high-risk group of patients. And if you're getting a bridge device, you're probably best case scenario in a 50-50 range in terms of walking out of hospital, which sounds horrible, but if you're getting a bridge device, medical therapy has failed, and without it, most would agree that the mortality is close to 100%. So there's a lot to benefit with a very comprehensive team-based approach to these patients. So bridge devices, rescue device intended for short-term use, support one or both sides of the heart. Of course, these are acute cardiogenic shock patients when it's unclear whether the patient's heart will recover or whether they'll be a candidate even for longer term therapies, being transplant or durable VAD. And what are the goals? The goals are, to really simplify it, improve the end organs. So this young man, when he was switched to Centramag, which worked really, really well for him, he healed up his pancreatic pseudocyst, off dialysis within about a week. His pneumonia cleared, which is probably more pulmonary edema and superimposed pneumonia. His liver function improved. Really, his multi-system was completely recovered, apart from his lack of mobility with the pump. And then, of course, in the recovery scenario, which is also important for the lungs, offloading LV wall stress and myocardial oxygen consumption are another goal of these temporary devices. I won't spend a lot of time on the history, but basically it's been well over 50 years since I guess it was Michael E. DeBakey that first approached mechanical pumps in end-stage heart failure patients. There was dismal success, I would say, back in that time, and it really wasn't to the rematch trial in the 1990s that LVADs were shown to be somewhat beneficial and really gained traction as we moved through the 90s, and then the HeartMate 2 era in the early 2000s. And that's when bridge to decision devices really became really gained exposure and became more popular in the treatment of these patients. And I'm talking about bridge to decision devices in addition to ECMO and intra-aortic balloon pump, of course, which have been around for probably 40 years. And they quickly evolved into to three scenarios: bridge to recovery of the organ, transplantation, and bridge to a durable VAD, which really the first durable VAD where bridge therapy was effective is the HeartMate 2 and HeartWare devices back in the early 2000s. more mid 2010, I suppose, for hardware. So the devices that we're going to largely talk about are listed here. Intra-aortic balloon pump, I'm not going to spend a lot of time on it. CentraMag we'll talk about because this patient used it. ECMO we'll talk a fair amount about. And then Impella we have here as well. We don't use it a lot. We do accept patients from other centers with them. Rarely, I would say occasionally. Tandem heart we don't use. There may be some experience in the room tonight with tandem heart. It has some similarities to CentraMag in terms of, centrifugal approaches or whatnot, but it's more of a catheter-based approach versus a CentraMag open chest approach, or minimal access approaches, I suppose, are also possible with CentraMag. And I'll just, for completeness sake, mention Abiomed BVS 5000. We're not using it in Edmonton. I'm not sure if there are any centers in Canada using it. What is the ideal bridge device? Easily implanted, transportable. If you're not a durable VAD or a transplant program, needs to be accessible, simple, and quick. Not that anything's simple in these patients. The ability to reverse anticoagulation safely, critically important. The ability to have complete biventricular support may be an important consideration in many of these patients. Easily managed in a critical care environment. It's an advantage in the ideal device to add an oxygenator if needed temporarily for the lungs. Add dialysis to the circuit, could potentially be done. And then durable is a relative term, but I'm going to say more durable than intra-aortic balloon pump and ECMO, which are really, in our program, a 5 to 7 day support, sort of 2 to 7 day support. Again, this patient's the exception. He went 14 days, and that's an excellent outcome in an adult patient for ECMO. Needs to be cost efficient. So who are these patients? We've talked a little bit about it, of course. Refractory shock patients, failed medical therapy. There needs to be a potential for meaningful patient recovery. So we'll talk about patient recovery and heart recovery. They're different, both important. So if the patient has a clear issue outside of their cardiac function, which makes it very clear that they're not going to have a meaningful recovery, then obviously they're not a candidate for bridge therapy. Like they've already had a significant stroke, or they come in with such severe comorbid conditions that are non-cardiac and this hospital admission related. They're not going to get a meaningful quality of life recovery. We're not going to push down this road, just treatment pathway for them. They need to have contraindications for long-term support at this point. Otherwise, they might consider going directly to a durable device. So these are usually some multi-system organ dysfunction patients. Maybe there's a question about their neurostatus. Hemodynamic instability is not a great environment or situation for a long-term device. If they have a significant coagulopathy or an active infection. And then I put down here an exit strategy is required if heart recovery is not possible. So in our institution, if they're not a transplant candidate or a VAD candidate, then they're not a bridge to decision candidate. So if there's an issue that prohibits, and this goes along for meaningful patient recovery, but it could also be something like non-compliance, if that's very clearly delineated in their previous medical history. So we need an exit strategy for them to be a bridge candidate. Who's the best candidate? Short durations, shock, minimal end organ failure, minimal comorbidities outside of their cardiovascular system, no contraindications to durable therapy transplant. And then that brings us into the discussion around device choice. Very complex, multidisciplinary choice in our institution, which I think is important. We're looking at the degree of shock. Is this mild shock or is it severe? Are they getting CPR? It has a significant impact on what we do the next step. How urgent is this? Very urgent in this patient, but not CPR. So it does open up some options. Is this a biventricular problem? And then finally, but not but also very important, I'll say, is institutional experience. So with a lot of these devices, Tandem Heart, Impella, CentraMag, there's not a lot, if any, evidence out there that states that one is better than the other to this point. And I think what really has an important impact on what you choose for an individual patient is your institutional experience. And that experience is also going to have a significant impact on the ultimate chances for a good outcome. So again, we go back to patient selection and timely referral. You need these two factors to have a reasonable chance at a good outcome in these patients. Who are these patients? Well, you have your high-risk PCI patients. That's more an Impella 2.5 patient, intra-aortic balloon pump patient. Cardiac arrest patient is your ECMO patient for the most part. Post-cardiotomy shock is another group you're going to be consulted on, which is a different group of patients. You already have an open chest, so there are going to be different considerations around what you use for that patient. Post-MI complications. So, VSD brings in a whole other discussion. Ruptured papillary muscle. You may or may not have an open chest, depending on the condition of the patient. Acute myocarditis and the cardiomyopathies, like this patient, of course. Post-heart transplant, early graft failure, and that can be left, right, or biventricular. Refractory arrhythmias is another group of patients, and that's also illustrated by this particular case. So these are the types of patients that your team is going to be asked to look after. So devices, intra-aortic balloon pump. I'm not going to spend a lot of time on it. It's been around since the 70s. When I went through my training and started in the mid 90s, finished in the early 2000s of my residency here in Edmonton, was really intra-aortic balloon pump and ECMO. At that time, we had a HeartMate 1 on the shelf, but it didn't get used during my training. Intra-aortic balloon pump has a selective utilization, mainly in our CCU. It's pretty rare in our post-cardiotomy patient population, but not unheard of. And the reason for that is it really only probably offers 0.5 to 1 liter per minute additional cardiac output. And our medical therapy, in my opinion, is so good that it can really accomplish everything that a balloon pump can accomplish. That would be opinion, not fact. So I would just finish by saying that it's rarely used in our institution, but we have it and it does get used, mainly in the cath lab and the CCU. ECMO we'll talk a lot about. I put the Revolution Sorin centrifugal pump. It's an LVAD that's not CentraMag or Tandem Heart, if you will, maybe a little less expensive. For a real crash and burn, unlikely to be a candidate for further therapy in terms of durable therapy or maybe even bridge therapy, but we need to buy some time to make a decision. If you're not going to put them on ECMO and they don't need an oxygenator, you can consider Biomedicus or Revolution pump. We don't use it very often, but we do use it. CentraMag is our mainstay here in Edmonton for that sort of short-term to medium-term bridge, and I would put that in the, really in the 3 to 14-day range, although as you can see in this patient, they can extend out for months. And I think we had an RVAD patient on for close to a year who left hospital post-transplant. So on the right side, you can go for extended periods of time with this pump. Tandem Heart, I'll talk about a little bit. Catheter-based, transcatheter-based approach. You have the Protect Duo, which runs off that same console for Tandem Heart. I don't have any experience for it, but that's a potential option for the right side. And then most of you know about the Impella 2.5, which is catheter-based. And then the surgical option is through a cut down on the axillary or direct aortic approaches with the 5.0 device. I'll talk a little bit about this paper, and for those attending who are writing their exams, this is a really, really good paper. It's 5 years old now, 2017. You'll recognize the Canadian names here, many of them critical care, heart failure, heart failure surgeons and medical physicians as well. Really good paper to review if you want to prepare a plan for your oral exam, say, on this topic of bridge to decision INTERMACS I therapy. And I'll show a few of these different flow diagrams, but this is a flow diagram that really narrows things down to, okay, is this an RV problem? Is it a biventricular failure problem, or is it an LV failure problem? And that will determine which devices you can use. So we can't spend a lot of time on it, but the patient presents with refractory cardiogenic shock. They got the multidisciplinary team in Edmonton. It's the shock team, for example, our MCS team, and surgeons, cardiologists are part of that. It's a really big team. And not just physicians, of course, all of the allied health disciplines, nursing, coordinators, et cetera. And then the patient presents perhaps in mild shock, where, here they talk about intra-aortic balloon pump or Impella, and then maybe even ECMO is mentioned here. In this patient population, we probably manage them medically, and then if they need a device, they're going the direction of CentraMag, durable LVAD, or ECMO. But in the bridge patient, it's going to be CentraMag or ECMO in this institution. Occasionally, we will use intra-aortic balloon pumps, like I say, but not very often. So if they're primary LV failure and they're talking, short term, you're needed, you need support. They list the options here. For us, that short-term again is going to be ECMO or CentraMag. We're not going to use Impella or tandem heart here. Intermediate term patient, you take ECMO off the list in our program, and it's really CentraMag is our go-to device. We have had a number of Impella patients that have been transferred in from other institutions, and I'll talk about the pluses and minuses of these options a little bit later. Post-cardiotomy, if it's short-term, we're ECMO, CentraMag, and of course, CentraMag can be set up as an ECMO circuit. We'll talk about that. And then they have the biventricular failure group, which are different options. Short-term, most centers, including ours, are going to go with ECMO in that situation. You can go BiVAD CentraMag with ECMO, but it's quite a bit more complicated at this stage, especially in the acute patient. The intermediate term patient, again, CentraMag. We don't use really Impella or tandem heart for that. We'll talk about plus minuses, as I've said, and then the post-cardiotomy patient, same thing. So there's a difference in cannulation strategies, perhaps, between the two, but the devices are very similar. RV failure, short term. For us, this is going to be CentraMag. Not likely ECMO, although it could be. And it could be CentraMag set up as an ECMO that can be removed at the bedside. And then post-cardiac surgery, same thing. Likely going to be a CentraMag, potentially short duration ECMO. And then you have all these other factors that you have to take into consideration. Pulmonary support, their peripheral vasculature, and these types of issues. So take a look at this paper. We'll talk about it a little bit further as well, and take a look at this flow diagram carefully. So some key points that I wanted to go over. These devices have evolved really, like I say, over the past 15 years since durable devices became widely used, I'll say, in heart failure programs, in advanced heart failure treatment. A common theme is there's very little evidence to put one up against the other. So someone who's going to sit here and say, look, Impella is better than CentraMag, or CentraMag's better than tandem heart, there's not a lot of information out there. There's some meta-analysis, obviously some retrospective studies, some case series. But it's such a heterogeneous patient population that there's really nothing out there that can directly compare these devices, and you can understand why randomized control trials in this patient population is very difficult. Again, patient selection, center comfort and experience. We've talked about that in the team-based approach. There'll always be newer and better devices. We hope there will be. And what you need is a team-based approach to implementing this new technology. So it's done in an evidence-based fashion, or as much as possible, but also when you bring in a new device like CentraMag, for example, that you're following your own outcomes. And we follow our outcomes very carefully. And I can tell you that in all of our bridge patients with CentraMag, for example, a little over 50% of them leave hospital. And that's in line with worldwide published results. I think if you're having 90% leave the hospital, you wonder whether you're declining patients that might have benefited. And then if you're 10% are leaving hospital, then maybe you're just operating on and offering this technology to a patient population that's just too sick and doesn't have an opportunity to recover or benefit. And then this is an important point. When you look at the latest INTERMACS publications, not only are destination durable VADs becoming the most common long-term VAD implanted, about a third of these patients, and there were a record number in North America implanted in the last year, I think something like 3,200, or maybe it was the year before, but the 2021 publication, a third of them went for their durable LVAD on a bridge device. And that could be ECMO, that could be balloon pump, that could be, CentraMag, any one of these devices. So a lot of these patients are getting bridge devices prior to their durable VAD, because you want them in as good a shape as possible before you put their HeartMate 3 in. It's a nice illustration of the team. The point that I want to make here, incredibly important, the patient's at the center. But it's a big team and everyone has a role. Social work, incredibly important. If you're going to go down the path of bridge therapy and maybe transplant or maybe durable VAD, social work needs to help us determine whether the patient and family are capable. Pharmacy, nursing, physiotherapy. Everyone has a critical role in establishing a successful program. I'm not going to spend a lot of time here. This is just another way of determining your device, whether you want to go percutaneous and surgical. And we've talked already a fair amount about that. So I'm going to skip through because I'm apparently a little long-winded here. ECMO, centrifugal pump, oxygenator, crash and burn, often a CPR type scenario. Can be post-cardiotomy as well, of course, done through a sternotomy. And everyone knows the cannulation, drain the right side and reestablish flow on the arterial side, whether that's femoral, axillary, or direct aortic. ECMO in the 1960s was really only determined to be useful for hours. I think we learned a lot through the pediatric population. There have been a lot of improvements over the past couple of decades, and it's an excellent short-term option. And survival to this hospital discharge is now in that 50% range in a lot of studies. In our program, it's a 2 to 3 day option. So if you're going on ECMO, be prepared to wean the patient off or move on to that next step really quickly. It's unusual that we'll leave them on longer than 7 days. Advantages, quick and easy to implement, can be done in the cath lab, CVICU if necessary, no sternotomy required, provides biventricular support, of course, and is a bridge-to-bridge device and cost-wise very reasonable. Disadvantage, short-term, peripheral vascular complications. I would suggest you use a graft or a distal perfusion catheter. And you have a window with ECMO. And weaning challenges, it's really hard to separate out, okay, is the RV recovering, LV recovering, lungs recovering? You really need all three recovering to wean them. So that can be a little bit challenging, whereas if you have a CentraMag BiVAD with an oxygenator, you can take the oxygenator out one day, You can take the RVAD out a week later and then the LVAD, and you can do it step by step by step. You don't need all three to recover to wean down therapy. I like this slide, window for ECMO. So over here, end organ function, not great, improves, and then it gets to a point where you can now make a decision to go on to the next device. They have the window here day 4 to maybe day 9. For us, I would say it's more day 2 to day 7. We would shift this window over a little bit, but as you can see, the end organ damage or morbidity accumulates with time on ECMO. So you have to hit the window to move on to the next step. And these patients need to be evaluated several times a day to optimize that. CentraMag, centrifugal pump. Easy to insert biventricular support. You can have an oxygenator, which is easily cut out at the bedside. Many of these patients, if I'm putting in an RVAD, I'll put in an oxygenator just in case. It's really easy to remove the next day if you don't need it. You don't want your patient going back to the ICU hypoxic and with high ventilation requirements. You can hold the anticoagulation for a period of time, reduced hemolysis. Of course, well described and well documented, evidence-based with this pump, and that's one of the reasons why it can be used for a somewhat longer duration. And that's related to the no rotating seals and the no rotating bearings, so it doesn't generate heat like some of the older pumps. An important slide. We're not going to have a lot of time to talk about this, but the point here is you have many, many cannulation options. I will mention that we like the LV apex cannulation because it empties that LV side. If your LV is dead and you're cannulated through the left atrium, you will run the risk of LV thrombosis, which is high risk for embolic events to the brain and other organs. So LV approach is our preferred approach. If they recover, this can be easily tied off at the end, can be done minimally invasively through a mini thoracotomy if you want. You don't need a sternotomy necessarily. Yeah, so definitely preferred, but obviously the LA approach is also possible. And then the one area where I will go out on a limb and say CentraMag is a really, really good option and probably superior to most, if not all, is the RVAD, isolated RVAD. And we see this in the LVAD patient with a struggling RV for a period of time in the transplant patient population. What I like about it is it can be put in through a sternotomy, which you're going to have anyways if you're in the transplant scenario or post-LVAD. For most of them anyways, unless you're doing it mini thoracotomy. You can't do this through a mini thoracotomy on the left side. Just put a graft on the PA, and then you can put the return cannula to the pump, either in the IJ or the femoral vein. And then this graft comes through the chest wall and we bury it in the skin. And then when it's time for the RVAD to be weaned and removed, we do that often right in the CVICU. You don't have to open the chest. You can run it for weeks at a relatively low risk. It's the right side. You don't have to worry too much about anticoagulation in these complex patients. You can run it at 2 liters if you just need that little extra support for a week or 2 in the transplant patient. I've evolved to the point where I used to really, really worry about RVADs and try to avoid them to, if I have any doubts, I just put it in. It's just so easy to remove in the ICU, and it's not worth taking the risk to not put it in if you have any doubts. So we only have a few minutes here. There is some data on CentraMag. This is from 7 or 8 years ago, but they did this meta-analysis looked at 1,000 patients. Of course, randomized control trial is not feasible. They determined what we all know, that early is better, and you have the results here in the right-hand column. VAD support in the precardiotomy cardiogenic shock patient. It's a good patient population to treat, and about 2/3 of them are actually going to be alive and potentially leave hospital at 30 days. Post-cardiotomy is probably the worst group here. Post-transplant 50-50 if you're needing a CentraMag post. I wouldn't include the RVAD patients in that. They do quite well actually and have a really good chance of leaving hospital. And the post LVAD patient population needing an RVAD, also good outcomes. Yeah, so the Impella device, most of us are familiar with this. Again, I'm going to refer back to this Canadian paper. I don't agree necessarily with all the points. I find this to be a very positional device. So minimal requirement for specialized support at the bedside, I don't agree with, because you're always getting called, or one of our physicians is always getting called to reposition as soon as the patient moves their, their neck or their shoulder or at all in bed. So they're pretty high maintenance that way and very finicky that way, is my experience. Generally, a catheter that would be used by non-VAD centers and then referred or transported to a transplant VAD center. And there's really no evidence that it provides additional outcome benefit compared to an intra-aortic balloon pump. But all the advantages and disadvantages are there. Of course, the advantage that it's a peripheral single site insertion. Tandem heart, again, catheter based, and you can see this catheter coming up the femoral vein and then the transeptal puncture. So you need that expertise. And there is a risk in a sick patient of trying to go transeptal and get into the LV. Not to mention, you can't move their leg at all. If this gets pulled back a little bit, then you have, the shunting possibility. It's an option. It's run through a centrifugal pump attached to the patient, of course. And the return, of course, is to the artery, either on the same side or on the alternate side femoral artery. And here's the Protect Duo cannula. I have no experience with it. I don't really see it at this point as a great option. It reminds me of the Avalon catheter for VV ECMO. Very, very incredibly positionally dependent. Here you got to get it just perfect, where you have the inflow through the right atrium and then the outflow port and the PA, and any movement whatsoever, and you're in trouble with this catheter. Not to mention it, you can't get it in and necessarily in all patients. These are sick patients. And in the BIVAD configuration, you can imagine you also have a left-sided catheter coming up into the right atrium, across the septum into the left atrium. So a lot of hardware inside the heart that can develop thrombus and clot and potentially embolize. So again, I've outlined for you here advantages and disadvantages of this pump. And there's no evidence to suggest that it's better or worse than CentraMag. We've talked about patient populations, post-cardiotomy, of course, post-transplant patient population, the dilated cardiomyopathy, post-MI patient populations. We don't need to go through that. Okay, let's see here. Sorry about that. So when? I don't think we need to go through this again. There is, largely INTERMACS I. If you have an INTERMACS II patient that's sliding on you, declining, perhaps quite rapidly, and you still haven't really made a decision whether they're, for whatever reason, whether they're a long-term VAD candidate due to uncertain neurologic outcome or status or improvement, for example, then you could potentially put a bridged decision device in an INTERMACS II patient, but largely INTERMACS I. I like this slide. It's for long-term durable VADs, but this is the patient population that we put bridge devices in. They're too sick for a long-term device. So in that INTERMACS I, maybe a few INTERMACS II patients, and then we try to get them back to a more stable status for a durable device. Another flow diagram, similar principles. Shock team, which we have here in Edmonton, and they're basing their strategy based on whether it's an MI patient, acute myocarditis, or a more longer term decompensated chronic heart failure patient that's presented acutely, and they go through their decision algorithm. And one more that's quite useful is whether they're listed for transplant or not, and how you go through destination therapy, bridge to decision, bridge to transplant. So you can look at those. Obviously, you're walking a thin, tight line on these patients. You have to tread very cautiously. Timing, if you're wondering whether they need the device, the time is probably now and not later. And I'll finish with this slide, who's a patient, former patient of ours that got all of these devices, ECMO, RVAD, LVAD, Centromag, and then LVAD, and then a second LVAD, and went on to transplant. He had his permanent LVAD for, I think, 11 or 12 years. Unfortunately, did not do well with the transplant component of things. So I think we have a few minutes, Abby, for questions. If anybody has any burning questions, I probably went over my time, so sorry about that.
No, Dr. MacArthur, you're totally fine. It was an excellent talk. Love to hear if there's any questions from any in the audience, or even just there's lots of different centers that are on the line. If you can maybe share, I guess, what your experience is with the INTERMACS I patient and what are your go-to devices. But thank you so much, Dr. MacArthur.
Somebody must have a question.
I
Steve,
see Joel's got his hand up.
Yeah.
Hi, everyone.
Oh, yeah.
Hi, Dr. MacArthur. It's Joel.
Hi, Joel.
Dalhousie. Nice to see you again. And thanks so
Yeah.
much for coming. That was a really exceptional talk. I wanted to ask if, when you're assessing either a patient who's undergoing CPR for eCPR or INTERMACS I patient, if there's any key indicators you look at in that moment, other than the past medical history and goals of care, that make you, certain about if the timing is right, if it's too late, will this patient fly, or you think it's too far gone? Is there anything you look at, or anything in your experience that is high yield?
Yeah, great question, Joel. And again, I'm not sitting here presenting here saying I have all the answers, but it's an important discussion. We need to continue to learn. We all get these calls, right? They're doing CPR up in the CCU. So the first thing I want to know is, how old is this patient? And if the answer is 22, I'm probably not going to ask what the lactate is. I'm going to ask, is this a witnessed arrest? And if it is, and they feel like they've had decent CPR and oxygenation, I might get them to draw blood gas. And then, we have the ECMO team or perfusion team coming up to cannulate them directly in the CCU. I think it's more complex than an older patient. So younger patients can surprise us. And I think even if you have a 1 in 50 chance of having a viable patient from a brain perspective, then I would argue that you can put them on ECMO at relatively low cost and potential huge benefit when mortality is death is the only other option. In the older patient, it's more complex. So if they're over 65 and you're doing CPR, and it's been going on for a long time and you can't get them back to a perfusing rhythm, I'm not saying we wouldn't do it, but we're reluctant after that birth date, not to discriminate according to age, but we know ECMO and greater than 65, the outcomes are just extremely poor. If they come in with 0 comorbidities and they're 65, and this is a short duration CPR, and of course, if they get return of circulation and a blood pressure, then the decisions change. Someone over 70, I would say absolutely not. I think the decisions are a little bit different in the operating room. So you're in the operating room and you can't get off bypass, then you'll accept maybe a little bit of an older age, since you've gone through the operation, they were a candidate for a complex operation. You can bring them back on ECMO for a couple of days, and some of these patients, it's a minority, but some of these patients get better, and many of us would consider that option in someone under 70, certainly under 70, maybe under 75 years of age. I look at history, so there may be an indication of compliance. You have to have some confidence that they're going to be a compliant patient at the end of the day, especially if there's no possibility for recovery. So, if drug use is a common scenario that we all run into, we're more reluctant, I would say, in that situation. We do use bridge devices. It gives us a couple extra days to make a decision in these patients if they're young, and then comorbidities. If this patient comes into this hospital illness or this cardiac condition with really a very poor quality of life. They can't, really get from the living room to the bedroom because they've got advanced arthritis and maybe some underlying dementia, then those comorbidities have a significant impact. Blood work does factor in. You'll be presented with a bunch of numbers. Again, if they're young, I don't pay too much attention to them. I mean, even if the pH is 6.9, if they're 22, I'm still going to put that patient on personally. I would accept arguments against that. They're 65, definitely not. Lactate, you're really encouraged if the lactate is 7.8 versus 25, for example. 25, it's probably not going to be a viable situation. So I don't know if that answers your question. The only other point that I will make is we're really, really lucky in Edmonton, as I'm sure most of you are here, to have a really, really solid team. And we have a discussion at the bedside, and it's usually quick if you're doing CPR, and we make a decision and we move forward as a team, and we support that decision, and we revisit the decision after ECMO has been implemented the next day, a couple of times the next day, and we keep working through that as a team. And that's a little bit different than when I went through my training a number of years ago. That was sort of more up to the surgeon. Surgeon made the decision. It was kind of all on you, and I think having many people involved in the decision is really, really helpful for the patient. What's your approach, Joel? What are your thoughts?
I think you outlined a number of very important items. The first being the patient's age and comorbidities. That's usually the first thing I will look at. In the ECPR population, of course, like you said, witnessed arrest and downtime. We have very strict criteria at our hospital, which our team knows, perfusionists know, the emergency room doctors know. So that's fairly standardized. I've noticed in the INTERMACS I patients, again, it's usually we're getting called from the CCU. Despite early consultation and early decision and early implementation of therapy, the outcomes initially the patient's course initially is positive, but then over time doesn't always work out well. And I think maybe that's just the nature of the beast we're dealing with and treating. But sometimes it seems like there's a point of no return for patients where they've been in shock for too long, and despite the decision at the bedside, the outcome isn't as good as we'd want. But I think with, like you said, time and experience and teamwork, we can maybe improve outcomes for everyone.
Yeah, I think the algorithms are really important. I would also say that you need to be prepared to make an exception to the rule. So if you have an absolute cutoff for lactate or pH or duration of CPR, be prepared to make an exception in an 18-year-old, right? So it's hard to fit all of our patients into these algorithms, but it's really, really also useful to have a starting point for making the decision. And to your second point about initial outcomes being very positive and then going downhill from there, I mean, this is the nature of these patients. If you're crashing CPR on ECMO, you're in that 50 to 75% mortality group. Yep. Versus 100% if you don't put them on. Our approach in Edmonton is if they're a candidate for another bridge device, move them forward really quickly. Don't leave them on ECMO for 7, 8, 9 days. If you can establish normal acid base and normal oxygenation in these patients, good flow and perfusion on ECMO, then switch them to the next device really quickly within 2 or 3 days, ideally, to avoid that downturn, which is inevitably going to occur and quickly in an older patient over 60, for example.
That's great. Thanks so much, Dr. MacArthur.
Yeah. What about Steve and Mike? I see you guys on the line here. Any thoughts or comments?
Yeah. Rod, so excellent talk. And I think can you hear me okay, by the way?
Yes.
Good. Yeah, no, so I think the real key is, as you say, is the team-based approach, right? So is to have a thorough discussion with your cardiologist and other members of the team is absolutely critical, because hopefully then you choose the right patient and they get managed appropriately. And And then, as you clearly demonstrate, there is many steps along the way. Once you put them on ECMO or even put in a short-term device, that's just the beginning of what is often a very long journey with many complex decisions. So having all those other people to help out with those decisions is absolutely critical.
Yeah. The other, thanks, Steve. The other comment that I would make is that, you know, we have an excellent national resource as well. So it's very, very common that one of us here, one of our team member surgeons will pick up the phone and call another surgeon at another institution in the country, run the case by them and ask them what their thoughts are. So I think we're very fortunate that way that we have a relatively small community where those relationships are solid and those relationships are built, and there's a lot of expertise in the country to help us out. So Saurabh, your hand's up there.
Yeah, thanks, Dr. MacArthur. This might be a silly question because I've never seen an LV apex cannulation of a CentraMag, but do you tunnel it under the subcostal region through a graft so that when you are weaning and you're taking it out in ICU, then you're able to just tie off that graft or clip it off as you're taking the cannula out and avoid going back to the OR?
Yeah, no, so RVAD, you really have that option, right? You can go IJ femoral vein and then a graft onto the PA, and you can easily tie that graft off. You don't have to open up the chest. With the LVAD, it's the LVAD approach, it's much more difficult. I'm not going to say impossible, but we haven't done that yet. As far as I'm aware, I certainly haven't. So my approach there is either a mini thoracotomy on the left. You can do this off pump, of course, put a couple of stitches in. You can do it on pump as well, which is even more controlled, especially if the patient's unstable. Put a couple of pledgeted purse strings in the apex where you anticipate the permanent LVAD cannulation to go. So it's really important that you make your hole in a spot that you're going to use later for the next step, right? This is a bridge device. And you can make the hole with the 11 blade, and I just put a Kelly into that hole. I don't even have to dilate the Kelly, and then the muscle dilates with the cannula. And I just use a bullet tip 28 or 30. And that's the other advantage I would say that we didn't get to. There's a lot I wasn't able to get to. The other advantage to CentraMag is you have big cannulas, and I think that's an advantage to the patient. With some of these smaller percutaneous access, like Impella is a great example, you get a lot of turbulence through small cannulas and a lot of hemolysis and end organ damage secondary to that. You don't get that with the larger cannulas nearly as much, so it provides you a longer bridge. So you can do that through a mini thoracotomy and then a mini sternotomy where you sew a graft onto the aorta for your outflow for the LVAD CentraMag, or you can cannulate the aorta directly. We haven't used a lot of grafts on the aorta for this particular device. I think we need to consider using more, and Steve and Mike are on the line as well, because one of the problems with CentraMag that I didn't talk about is if you have someone on for 2 months, they also move around a little bit in bed, and these cannulas can get pulled on and position changes, and you're only in 20, 25 millimeters, and potentially that cannula could get pulled out and you could get bleeding there. And we've had a couple of those patients over the years. So if you put a graft on, then you prevent that problem, and maybe you can even deal with that without reopening the chest, and then through the mini thoracotomy and not reopening the sternotomy, if you will, deal with the apex if they're a bridge to recovery. Most of these CentraMag patients are not bridge to recovery. They're bridge to a bigger operation, transplant or LVAD. So many of them we're doing through a sternotomy. You want if you're doing the apical cannulation through a sternotomy, you pretty much have to do it on bypass, I would say, because, you know, lifting up the heart, getting that exposure in an unstable patient can be very difficult, not impossible. And then the second thing that I would say is whether you do it through a mini thoracotomy or a sternotomy, line your cannula up. So you have to anticipate where that apex is going to be in the decompressed heart and make sure you're coming out laterally enough. The tendency is to put it more midline, and then you get a real kink in your cannula, which can be somewhat difficult to manage in the ICU. So line that cannula up so it's going straight into the ventricle. If you decide to cannulate the pulmonary vein, Again, we've talked about the issue of LV thrombosis. You can consider a bullet tip right through the mitral valve, and you can still get that cannula into the LV apex and perhaps not even have to go on bypass to put the LVAD in through the pulmonary vein and aorta. That answer your question?
Yes, sir. Thank
We
you.
haven't used a graft on the LV apex to this point.
Yes, sir.
I'm
Thank you.
not sure how solid that would be necessarily. Yeah, we've used it for RVAD patients with RA cannulation, PA, and for the RA and the PA, but we haven't used it on either the pulmonary vein or the LV apex.
Got it. Thank you. And in the case scenario that you presented earlier with the 22-year-old, you mentioned that you had the cannula go in through the right superior pulmonary vein, but it did not cross the mitral valve. And you were going to talk about sort of why that is later, or the importance of that.
Yeah, yeah.
I may have missed that in your talk, and I apologize for that. Would you mind just explaining the importance
Yeah.
of not going through the mitral valve in that patient?
Yeah, so this worked out really well for the patient. It wasn't our cannulation strategy, it was the referral center. It worked out well. I don't think they anticipated having the LVAD in for 3.5 months, so that led to other issues at the time of transplant. They had a 24 metal tip, I think it was, into the right superior pulmonary vein, and they got 5.5 liters from this cannula without difficulty. That cannulation strategy can be a little bit finicky flow-wise, position-wise for the patient. For patients, it wasn't for this patient. And he had a really, really poor LV. So where you run the risk, if the LV is not ejecting and opening up the aortic valve, when you empty out the left atrium, you get stasis in the LV. And we've seen a couple of LVs thrombose, and that becomes a non-viable situation. So in someone, we got away with it with this fellow. So obviously he was managing to have some blood flow through his LV and out the aortic valve. He had some layered thrombus in the LV, but not much. So in order to avoid that issue in the really shocked dead LV, you have to empty out the LV, and you can do that through apical cannulation, or you can go through the pulmonary vein across the mitral valve and get your LV cannula that way. Interestingly, in this patient, I did his transplant. One of the issues that I didn't anticipate is the tourniquet's holding this superior pulmonary vein cannula in the right chest, because it was in there for 3.5 months. Had staples and ties, and the tourniquets, they were just completely plastered to the lung. And to identify structures and not injure the lung, really, really difficult. And now the heart's arriving in the room. So what I ended up doing is just cutting the purse strings, leaving the tourniquets in the right chest, doing the transplant. And later on, once we were drying up and things, I spent 2 hours, because I didn't want to leave the plastic in his right chest. I spent 2 hours locating these cannulas and getting them out of the right chest. So this is one issue that perhaps we didn't anticipate with this mini thoracotomy approach to this particular LVAD. So interesting, worked out really, really well for this patient. That's going to be one of the downsides that will factor into the next complex decision. Yeah. Anything else, Abby, or how long did you want to go?
Yeah, no, so is there any other questions from the group? Usually just at this point, we just wait. Sure. If there's any other questions, and if there is none, then we will let everyone go on with their evening. Any other questions or comments?
Thanks a lot, Dr. MacArthur.
Yeah, no, this is really good, and I'm more than happy to do another Zoom meeting if it's useful to residents, students, fellows preparing for exams, whatnot. It doesn't have to be a formal recorded YouTube video, but there's